think this is what we got to. Addison's disease. We were talking about the adrenal glands and abnormalities with those. We talked about pheochromocytoma, which is a tumor that secretes catecholamines and things. So Addison's disease, we have Addison's and Cushing's, and these are two disorders of the adrenal glands. One's hypo, one's hyper, just like the other things. They're going to be pretty much opposite. So, and with these, you have more fluid and electrolyte imbalances because of the function of the mineral corticoids. But anyhow, so Addison's disease, also you can think of it as low adrenocortical hormones. So adrenocortical insufficiency. So this is low adrenal glands, and with most endocrine disorders, it's more common in women. Could be autoimmune. Here's some other causes. Could be familial or genetic, and so also this can be brought on by discontinuation of long-term steroid therapy. So maybe you're familiar with steroid therapy, and that it can't be stopped abruptly, and if that happens, you'll have symptoms. And basically, you would have symptoms of Addison's. So it's just an insidious onset. It's not going to happen acutely like most endocrine disorders. So the adrenal glands, for some reason, are producing less than enough amounts of steroids and aldosterone. The body initially in the disorder will have enough steroids produced to compensate. So they're fairly without symptoms initially, but this is a progressive disorder. So as the person is in states of stress and the disease progresses, the symptoms become more evident. Does that make sense? So remember that we need steroids for life, right? So this person becomes unable to properly respond to stress, and that is not a good situation. Elevated adrenocorticotropic hormone, trying to get the adrenal glands to produce more, but they can't. So these are signs of low steroids, basically. The person will be tired, weight loss, lots of GI upset, possibly some changes in blood pressure. Okay. One key thing that you'll see probably frequently, maybe in boards in HESI, is that Addison's, people often think about this bronze-colored skin, so darkly pigmented skin. From what I remember, I think it has to do with the elevated adrenocorticotropic hormone, the ACTH being high. It causes the skin to be bronze. Also with the changes in melanin related to Addison's disease. All right, so this person is dehydrated and they are intolerant to cold. So this person also note that you have these fluid or these electrolyte changes. So high potassium, low sodium, low glucose. When I study with pictures, and there's a picture somewhere that I've looked and looked and looked for, and it's one of those things, like my picture with hypothyroid, that person with the eyes and the fan in front of them. This one was Addison at the Salt Lick. So like this person was really small and dark skin and looked terrible and was licking a Salt Lick because they were hyponatremic. So Addison at the Salt Lick. So they're hyponatremic, hyperkalemic, and low blood glucose. Okay. This is not the picture, but this one will work. So you notice there's hirsutism here, the facial hair in women, the skin is kind of dark. All right. So cortisol is one of those, it helps to measure the level of steroids in the blood, so that level is going to be low, of course, and the ACTH level would be high because the body is trying to say, we need more steroids, give us more, but the adrenal glands are not producing. This is a good test. This is called the ACTH stim test. Sometimes people will call it the cosinotropin test, but you're giving cosinotropin. So the way that this test is performed is that you will draw a cortisol level. Just stick the patient, pull blood from the central line, just draw a level of cortisol. And then immediately we give IV cosinotropin, which is synthetic ACTH. The ACTH should stimulate the adrenal glands to produce more cortisol. Naturally, that's what happens. So after an hour or so, we draw another level, and in a person with normal adrenal function, that level will increase. That's what we would expect to happen. So that's a normal test. But without a change, or maybe even just a small elevation in cortisol, that would indicate that the patient has hypofunctioning adrenal glands. Okay, so they're not producing steroids. These are a few nursing considerations. So obviously, if the patient's getting routine steroids, we wouldn't give them their IV solumedrol and then do this cortisol symptom because you would get a false positive. And the stress can elevate steroids and cortisol. And this is done early in the morning because the adrenal glands are most active then. They're more easily stimulated early in the morning. I think in a person who has a normal sleep cycle, not nurses, the body produces a cortisol surge late or early in the morning, around 5 to 7 a.m. So maybe even earlier. And the test would be performed in the afternoon or the evening because that's when the adrenal glands are less active, and so that would help us test for adrenal hyperfunctioning. Does that make sense? So if we don't have steroids, we need to give them steroids, right? We need to get their sodium up, and we need to get their potassium down if possible, all right? Or if it's high. So these are some basic steroids. I'm not going to talk a whole lot about steroids. I think that you probably get steroids along the way and everything. But if there ever was a time that you really need to know steroids, it's now. And some medications you just learn every place that you're constantly learning about it. And these are medications that I know that you're constantly learning about. So I'm not going to go through everything about steroids. I think that you're pretty good at it. In your book, on this page, there's a little box, and it tells you everything that you need to know about steroids for my purposes. Vivian has a copy of it. Yep, I see it. All right. But realize that some steroids replace the glucocorticoids, and other steroids replace the mineral corticoids. Remember that our body needs more steroids in times of stress. So if our patient is on long-term steroids for Addison's disease and they have to have surgery, we might need to increase their steroids during that time. They need more. So, with most of these disorders, we can have some sort of crisis that can happen. Addison's is no exception. So we call this an Addisonian or adrenal crisis. So, of course, it's going to be the signs and symptoms of Addison's disease, but those signs and symptoms are going to be exacerbated. And they're going to be exacerbated for some cause. Usually, stress, surgery, all of those things. These things cause stress on the body. Emotional stress is maybe what I meant here, without just stress. But probably the most common reason that this would happen in our patients with Addison's is them stopping their steroid medication. They ran out, they forgot, they're non-compliant, whatever. Somebody didn't give it to them if they have to have medication given to them. So this is what happens, an Addisonian or an adrenal crisis, when you stop taking steroids abruptly. Remember that, when you have bronchitis and they give you a metronidase pack, or when you have asthma and they give you prednisone for 5 or 6 days. That's not a big deal. You just take it every day, done. But it's long-term therapy that you have to worry about. Even the Medrol dose pack, I don't like Medrol dose packs. I don't think it's enough, number one. But also, they taper it off it's unnecessary to taper it off. It's not long enough to cause suppression or serious suppression of the adrenal glands. So that's what happens in that situation is that when you give someone long-term steroids, the adrenal glands, if it's for a reason other than Addison's, because Addison's adrenal glands aren't working, but if you're giving somebody long-term steroids because maybe they have rheumatoid arthritis or multiple sclerosis or something like that, the adrenal glands get lazy. So basically, giving this medication that would come naturally from the adrenal glands to the body saying, you've got enough, ACTH doesn't kick in and say we need more, so therefore the adrenal glands get lazy. And the adrenal glands are hard to wake up. So the patient will have an adrenal crisis. And in that situation, when we talk about an Addisonian crisis, we have the risk of severe hypotension and circulatory collapse. So that's a big deal, right? High fever goes along with this too. In the person with an adrenal crisis, we have to make sure that we get their fluid volume status up, give them fluid, give them steroids. Support the circulatory system. And also, of course, remember that weight is a very good indicator of fluid volume status. One liter is 1 kilogram, right? So we talked about the deficient fluid volume, weight, blood pressure, intake and output will tell us a lot about that. Because of the alterations in sodium and potassium, remember the patient is hyponatremic, hyperkalemic, and especially that hyperkalemia can cause some conduction problems, some dysrhythmias. In the patient that has low sodium, we have to be careful with that because in the person who is hyponatremic, we can't just give them a whole bunch of sodium and bring it right back up. We can't do that. Because if you give a patient who is severely hyponatremic, maybe their sodium is 115, we see it all the time. You might think, well, you just need to give them much sodium. You have to give them a small amount. So you'll see the orders written to give so much sodium and monitor closely. Because if the sodium rises too quickly, it causes damage to the neurons and it can cause cerebral edema. And your patient can have lots of problems because of that. So closely monitor your patients who have hyponatremia. Those patients will probably be in the ICU they probably will just start with either half normal saline or normal saline. Because that, of course, has sodium in it. And that's going to slowly rise the sodium. All right. Orthostatic hypotension. Know those interventions that you do to prevent orthostatic hypotension. Right? Perhaps the reason that the person is in this problem, like I said, is because, they stopped taking their medication or they're not taking good care of themselves. Their body's continuously having times of stress and they need to better learn to maintain their health so that they don't have exacerbations of Addison's. That's Addison's. Cushing syndrome is the opposite. So know that in Addison's, that person is going to be, hold on, I'll compare it to the same. Hypercortisolism. So the other one, it's adrenal insufficiency. This is too much adrenal gland activity, too much cortisol, too much steroids. And this could come on because the person, again, it has to do maybe with the long-term treatment of steroids, not the abrupt stopping of it, but or whatever. It's the effects, the side effects of those steroids over a long period of time that's causing them to have this syndrome. Maybe the pituitary gland is producing too much ACTH, or maybe there's a tumor somewhere that is secreting ACTH. Remember that tumors are notorious for secreting hormones, and that can cause problems. So basically, this is simple. Too much cortisol, too much steroids, right? So we would have an elevated cortisol level, and the ACTH here may be low to compensate for we have enough, but it also may be high because it's not communicating correctly with the adrenal glands. So the ACTH remains elevated even though we have an elevated steroid. That means that there's an alteration in communication here. The adrenal glands and the pituitary are not talking correctly. Right? Does that make sense? I'm sorry, Eva. She was yawning. So the manifestations or signs and symptoms of Cushing's is going to be related to the elevated steroid level in the blood. So this here, right here, this abnormal fat distribution, this is what we can see very easily. This is classic with a person with hypercortisolism. The buffalo hump is basically like a humpback. They have a fat pad on the upper back, lower neck. The moon face means the face becomes very round. It's an effect of long-term steroids. And then abdominal obesity, and usually with Cushing's, if you have the abdominal obesity, the person will have very, very thin arms and legs. So the obesity is just central, truncal. All right, what else? Osteoporosis is a big risk factor here. Hirsutism, again, like with Addison's. Emotional lability means unstable emotions. This person doesn't cope with stress very well either. So the electrolyte imbalances will be opposite of Addison's. So just remember that, hypokalemia here and hypernatremia. It's the opposite of Addison's. I always think about the glucose level following steroids. So I just kind of think of glucocorticoids. They elevate the glucose level. So just realize if you have too much steroids, high glucose, not enough steroids, low glucose. High cortisol level with this. This is the dexamethasone suppression test. It's similar to the cosinotropin test. So what we do here, again, is we draw a cortisol level. We also are looking at the urine. Here we give dexamethasone. We don't give cosinotropin, we give dexamethasone. We give it at night, and then we draw the cortisol level early in the morning. We also draw another follow-up urine. So what we are expecting here, or what would be a positive test, is if the adrenal glands are overactive, if the adrenal glands are larger than they should be, producing too much steroids, the cortisol will be lower after dexamethasone given. But if cancer is the problem, the levels will not change or maybe elevate. All right? I don't know what it stands for, but it's.
I thought maybe I didn't hear it.
No, it's one of those things like the byproduct of cortisol. So if it's around, cortisol is around. Caffeine can cause a false test here, and not a lot of glucose or anything, and MPO. And also remember that when you're doing these urines, collecting urine over a long period of time, or have to hang on to it, 24-hour urine, usually we're keeping it on ice or in the refrigerator. Some facilities you don't have to. Like at the Med, you don't have to put urine on ice or refrigerator when you're keeping it. But most places will make you refrigerate urine. So you see that this person looks quite opposite from the lady with Addison's disease. Truncal obesity is one of the first things you see. You see a round moon face. This person may have risk for fractures and due to osteoporosis, thin skin. What else? Increased risk of infection. That's a big one. So what we need to do here is, if we have too much steroids, too much cortisol, it needs to be kind of lower, right? So if the problem is a tumor, they may remove the tumor, or they may remove the whole adrenal gland. If the problem is that the patient is on long-term steroids, they will hopefully decrease the dose if the person is having signs and symptoms of Cushing syndrome. If the problem lies with the ACTH, and if there's a tumor, we can get rid of that tumor maybe through pituitary radiation. Did I already talk about an adrenalectomy? It seems like I did. I did? Let's talk about a pneumothorax. Whatever. Let's see what else we need to talk about here. So the reduction of stress pre-op, realize that stress causes the secretion of cortisol. We need to keep the electrolytes as normal as possible. This person should be on a high protein diet, low carbohydrates because they have hyperglycemia, right? Oh yeah, we talked about the removal of the pheochromocytoma. So if the adrenal gland or glands are removed, the patient will be at big risk for now hypoglycemia because we're not producing glucocorticoids, and they now would be at the risk of having not Cushing's but having an Addisonian crisis. So circulatory collapse, closely monitor the cardiovascular system. But realize that cortisol and all the steroids, they don't just go away. They will circulate in the body for a period of time until they're metabolized off. So this person's not going to have acutely, probably will not go straight into Addison's disease. So probably post-op they will still have some signs and motions. And again, this is some signs of Addison's, right? Low sodium, high potassium, and low blood pressure. The person with Addison's was fluid volume deficit. The person with Cushing's is going to be fluid volume excess. So all those interventions related to the monitoring of fluid volume status, weight, and all of those things. And remember also to monitor your patient's respiratory status when there's fluid volume excess because of the risk of pulmonary fluid restriction, and risk for injury related to fractures and things related to osteoporosis and things. So decrease the patient's risk for falls. So hopefully they can prevent them from falling and breaking anything.
Mr. Sampson,
Yes.
you said respiratory status. You said there's a chance of pulmonary
Edema. Because of fluid volume excess. Yeah. So when too many steroids are in play, the person is at increased risk for infection because the immune response doesn't happen properly when steroids are elevated. Also, steroids, the effect of them is anti-inflammatory, right? So they can mask also the signs of infection if infection is there. So it can actually kind of help exacerbate a problem because the immune response isn't working right, and then it has to do with the anti-inflammatory. Inflammation has to happen in order for the immune system to kick in and for the white blood cells to work. But also, just in general, these medications will mask the signs of infection as well. So all of those things, as nursing students and almost nurses, you're very good at preventing infection. Right? It's one of our priorities. So the bodily changes related to Addison's disease might cause the patient some stress. So assessment and counseling for things like that.
Mr. Sampson,
Yes.
like with Graves' disease, how the exophthalmos is not reversible. Is the buffalo hump an infection?
I was just thinking that. I think that once the person develops the buffalo hump and the moon face, I think that it can improve some, but I think that it never fully goes away because it's the distribution of fat in abnormal distribution. So, I think that it will improve, but I think I've heard that it won't completely go away. All right, this is the last thing we need to talk about, I think. So, primary aldosteronism. Remember that the adrenal glands also secrete aldosterone. So this is too much aldosterone. And this may be due to, again, a tumor or something that is secreting aldosterone or overgrowth or large adrenal glands. The big thing here is hypertension. So we think about the person being at risk for hypertension when they have primary aldosteronism. the majority of the time in our population, when someone has hypertension, it's primary hypertension. It's hypertension because of genes. It's hypertension because you have a body diet. It's hypertension because you have weight. That's primary hypertension. But there is a chance that the patient could have an alteration in aldosterone causing hypertension. That's secondary hypertension. So we have too much aldosterone being released, and then we have that causes potassium to be excreted, and then we have hypernatremia as well. This leads to fluid volume overload, leading to the hypertension. Got it? I'm so excited. Here we have high sodium, low potassium, and these, hypertension again, which would lead us to risk of cardiac dysrhythmias, enlarged heart. That's HA's headache. This person, it's unique that they don't have edema, and that's because all the fluid is where? In the vascular system. So the person would have an elevated sodium, so the fluid is retained and fluid is shifted intravascularly and is pulled out of the cells. So therefore, the fluid in this person is all in the circulation, causing the hypertension. Because many times these are patients in shock, and all their fluid is third space, but in the vascular system it's low. So that person's hypotensive. Aldactone is a good treatment here. This medication is, a diuretic, but hangs on to potassium. So in this situation, potassium is being wasted. So this is a good diuretic to use because it hangs on to potassium. But at the same time, it gets rid of that excess fluid. Calcium channel blockers like amlodipine are also some of the first-line antihypertensives for primary aldosteronism. If it's a tumor, of course, we can remove the tumor or remove part of the adrenal gland. And because of the hypernatremia, of course, sodium restriction. So no, all of those foods and drinks and things like that are related to or that have high sodium. So all those things that we teach our patient not to take. No sodium restriction. We talk about sodium restriction, and we think about a 1 gram restriction, on 1 gram a day or maybe 1.5 grams per day. But the normal recommended daily intake of sodium is what? No more than 2, max 2, maybe 1.7. So, that's hard to do. So it's really hard. So realize that a restriction is really not a lot less than the daily intake. And most Americans exceed that daily every day, 34 grams of sodium this week. All right. So that's that. Wasn't it exciting?
It's taking so long to get through endocrine.
I'm so glad it's over. I think next semester I'm going to put it down for 3 days, and I'll make cardiac 5 days. So we've rushed the cardiac. But, we learn from experience, right? Y'all have any questions? Let's see. Let me stop this recording.